I have had the privilege for over 30 years to look after people who experience wounds. In those first 28 years, it was in an acute care domain. And for many of those 28 years, I had the privilege of being the lead nurse in a leg ulcer clinic. As that time drew to a close and the particular institution I was working in changed its ethos and direction, I gained the opportunity to do something I had never considered previously, and that was working from a wound management perspective, but in a rehabilitation setting. And it really now, for most of the rest of this presentation, it is the thought pattern, it is the direction, the sensibilities, and in fact the ethos of rehabilitation that I want to share with you, because it is there I've actually begun to discover what patient-centred care actually looks like, what it is, and what it delivers. The hospital that I work in the northern suburbs of Sydney, we have these domains that we, by and large, adhere to. We do a lot of knee and hip and spinal surgical recovery work. We see folks who've had major surgical procedures, and sometimes these have been as a result of significant trauma as well. We do see, we are in fact a major spinal cord and brain injury centre for all of the east coast of Australia, not just for New South Wales. And our lymphedema unit is one of the busiest lymphedema units in Australia. So there's a really good range of portfolio where every time I go to work, I have the challenge to learn and engage and extend what it is in my own mind that I'm trying to achieve. And what I like about the pictures of young Einstein is that what if we could do all of these rehabilitation sectors and we did them all at once for the one individual? Should that be possible? It is really only Frankenstein that I can consider should have each of those domains, should we deliver all of that at once, one person at one time. Thankfully, I have never encountered such an individual yet. But you never know. I mean, you do have Boris Johnson after all. I remember being told when I left the acute care sector, they said, when you go to rehabilitation, is there a risk? A small risk? You could be a bit bored? I want to show you a few wounds from the last 12 months of the rehab centre that I work in. Am I bored? I don't particularly think so. So over a cup of tea, let's look at a few. On the top left is a beautiful 84-year-old individual who required a 12-lead ECG, and on the removal of the dots, one recalcitrant dot managed to be removed with a little bit perhaps too aggressive force, and we have a skin tear. Here is on the other side a beautiful older lady who was in fact a pedestrian in a motor vehicle accident and suffered significant brain injury and has had a shunt put in to try and drain some CSF fluid. And it was interesting that over a period of some days she became increasingly more restless and agitated, and an unusual discoloration began to occur behind the right side of the head. And then what became apparent is she was developing a pressure injury. And when the necrotic tissue was relieved, people were thinking, what is this that we're looking at? But it is, of course, the shunt device itself. We have on the bottom left somebody who is undergoing some chemotherapy and has had an unusual reaction to this chemotherapy and has had multiple areas of full thickness skin necrosis. On the right-hand side, an individual who has had peripheral arterial disease, also coexisting with diabetes. The great toe has been removed, but this person's now very challenged for that amputation site to close. So we're seeing a surgical site infection, a dehiscence of a surgical wound, but with the comorbidities and underlying anomalies, we are finding somebody challenged to now achieve closure of this wound. All of these were challenges for us in our rehab setting. But we have others. In our lymphedema unit, we regularly see people who have very large BMIs. This dear gentleman has a BMI of 62. massive individual. And because of the profound effects of the lymphedema, we have these huge pseudo-tumours that he's living with. And with this, you have the breakdown of tissue, and you have these moisture-associated skin areas where we see lymphorrhea, an actual lymphatic fluid pouring out onto the skin. We have mixed arterial venous ulcers. We have the head of an individual who had a squamous cell carcinoma, had a recurrence of that carcinoma, and after having had radiotherapy for that recurrence, now 4 months later, we are seeing the loss of this graft because of the radiotherapy to treat that recurrence. And unfortunately, we're now seeing honeycombing of the bone. And yes, there is in here meningeal covering now exposed, and the fluid that is weeping out is indeed CSF. This is most challenging to see in a rehabilitation environment. This individual's had necrotizing fasciitis. Went fishing one day and found that, unfortunately, the fish hook, when he went to cast off, didn't quite clear his trousers and managed to score the inside of his leg. And unfortunately, the river water was not that pure. We'd had a period of some degree of rain and therefore some local flooding, and the effluent content of the river was much higher than normal. And thus, we have the mode of injury, and we have the actual mechanics of the microbiome of these organisms, and necrotizing fasciitis took hold. We didn't see him in rehab with the acute event, but we're getting to look after him in the recovery thereafter. So wound care and boredom in rehab does not really exist. Wound care and challenge and perpetual learning, yes, that is exactly where we're at. So who is our rehab team? In Australia, we have the Australasian Rehabilitation Nurses Association, a key entity of which I'm now privileged to be part of. But when they look at who is it that is part of the rehabilitation family group, we do talk about various numbers of medical officers, those for whom it may be part of their career approach. They remain in the rehabilitation environment as part of their remit. Others are visiting medical officers. Our occupational therapists and what they do, physiotherapists, speech pathology, down to dietitians and so on. But where I work, we have, because of the CEO of where I work, an interesting, all-engaging ethos that says anybody who works at this hospital, if you engage in patients in any way, then all of us are responsible for the one individual in our care. So our team is also made up of our visiting podiatrist, our housekeeping staff, the drivers who bring people in and out for day surgery or for day procedures or for daycare therapy sessions. And then, of course, we include the clients, their family members, their mothers, their sons, their daughters, even their neighbours, if it's the neighbour who's likely to be providing care. All of these people become engaged in what we refer to as our case conference. One of our case conferences recently, before we came over to the UK, was of somebody who has been recovering from their stroke. They're actually due to be going home in 2 weeks' time. And one of the important things that this person must do in 2 weeks' time before they go back home is they must be able to demonstrate that they can cook their own meal, and that they can cook their own meal and they can eat it. Because if they can do that with us, we have a greater degree of confidence they can do that when they get home. Well, the speech pathologist and the occupational therapist said, oh, we've ticked that box. This person was up in our rehab kitchen. This person produced their meal. But it was the housekeeping staff member who found 2/3 of that meal was in the rubbish bin. They were not able to engage in the physical eating of that meal. That person's not ready to go home yet if they can't sustain adequate nutrition. The key person in that case conference was the housekeeper. Who would have thought? But how appropriate that that was the case. There is this quote that I love, and that is there is ample evidence within the rehabilitation circle that if you can get people from all different kind of orientations and backgrounds, but they come together for that one person with shared goals, then we can begin to achieve things that matter and achieve things that are long term. In Australia, and I don't know if this is like for those who may do rehabilitation here in the UK, and in fact, may I ask for a show of hands, is anyone here engaged in rehabilitation care at all? Is this functional independence measure, is that something that you're using? Is that, I understand that this is an international kind of a scale. If we look at what the functional independence measure is, it is actually broken down under all of these headings. And this talks about your ability to self-care, your ability to maintain hygiene and activity, your cognitive capacities. And each of these is actually a measurable item. And there's a beauty in the fact that this is measurable, because some of our patients will be strong in some areas, but be challenged or have weaknesses in others. And if you can measure this and give this a number, we can then say, okay, today, this is where we start with your ability to feed yourself. This is where we start with your ability to improve your short-term memory. This is where we start with your capacity to transfer from your chair back into bed or onto the toilet. And then as we see how we progress, we can now say, are we achieving what it is that we're intending to try and to do for you? Is our therapy worthwhile? Are we being goal-directed sufficiently to meet your needs? And I like what is listed on the left, because this is all about really the person who is the consumer, the client, saying, what do I need to achieve? You know, what happens at the end of all of this is that in this context, we need to say is, how can you be the best you can be today? And in order for you to be the best you can be today, what does that look like? How do you measure it? How do you give that a number? And that's what this scale is all about. Now, I guess it's the same here in the UK as it is in Oz, that what we measure, what we achieve over time with this scale is how we are funded. We are funded because we can demonstrate that we make a difference. And we demonstrate this by something that then is a scale and a tool. And it is something that every member of the rehab team has an input into. But the key in this is the central point of input is always the consumer, and usually their key family members as well. This is all built up around them. Person-centered care is kind of summed up by this definition, talking about the person's preferences, needs and values. And that is great, but I also like the other aspect to this, and that is that all of this is done by looking at the feedback that comes from the end user. In other words, this is an ongoing, multiple-way relationship, which is measurable, but it relies on this intimate communication between all parties, which is exactly what Zena was referring to. And I thought what she had to say dovetailed into this so very well. So we need, therefore, if our patient is going to feedback to us and communicate to us, this leads into other aspects of how intelligent are our clientele about what it is that they face as their comorbidities, as their actual disability or their underlying problem that they're there to be treated for. What do they know about it? What do they know about then the likely therapies that can be offered? Their work of patienthood, is that a term that you're familiar with? If I'm to say to you, I want to be part of your care, but to be part of your care, you've got to be setting goals. You've got to tell me what you believe your preferences are likely to be, what you can and can't do, what you can commit to. Because we're going to measure what we achieve together, but you've got to do it, and I'm going to do it with you. And what is it that you understand about this process? Because really you have to have this person involved and committed. We actually don't admit people into our rehab institution unless they are able to tolerate a guaranteed 3 hours of therapy each and every day, that they can sign, they are prepared to be committed to it, they understand why they're doing it, how they're doing it, and the fact that it's going to be measured and therefore funded. So all of this actually becomes part of our agreement before we even begin day one. But it involves their work of patienthood. They're part of this. And we don't do it without them, and we certainly don't deliver things. It's not a case of saying, I'm here as a patient now, please do this for me. That is not the case whatsoever. So what does this person-centred care look like? Our Victorian state government, when we are looking at when they are talking about rehabilitation in the state of Victoria, this is what they want it to look like. That we do give people their dignity and their respect, that we are looking at tailoring care to suit their needs, that they need to understand the nature of their problem and their challenge and the therapies that they can choose as to what those therapies might do, what they might achieve, what they may entail. I like this bit down the bottom, that we must involve you in your healthcare decisions at all times. And I've taken a pause there because I know the next slide. Involving you in your healthcare decisions at all times. What could that possibly look like? Here is an example. We don't do this in rehab that often, but do you want to have the deluxe colonoscopy using a tiny fibre optics camera, or the economy procedure using the hamster and GoPro helmet? In other words, whatever procedure we're going to offer you as a therapy, it is nice that you have a choice. We will give you a choice whenever possible. And yes, it might have an implication for your finance. It might have an implication as far as what you have accessible within your local community. What is interesting is that since this particular picture was published, in these days of austerity in the UK, we now realise that you are particularly short on hamsters. However, to be fair, we are now aware that within the UK, the hamsters are being replaced by ever improved and well-trained squirrels, which I believe, inserted in this manner, can give you some degree of rectal flossing as well as expert images. So what I'm painting here is something that I have learnt within the rehab setting, and that is of a cohesive group of individuals who are very focused around the client, what the client's problems and challenges are, what their etiologies may be and their comorbidities and how they influence them, and really seeing that our way forward is that it's all of us together. And as I was learning this, I thought, well, this is such a marvellous way of being able to say, well, is our wound care like this in rehab? If we have this functional measure of independence and we can gauge how we're going, surely we must be doing wounds the same way. Alas, we're beginning to do that, but we have not historically done that. The more I think, the more I get confused, and that is certainly applied to wound care in the rehab model where I've had the privilege of working. As I begin to break out the Murray Mint, a slight diversion. 3 years ago, I went to the Mount Wilga private hospital, which is the rehabilitation centre I'm now at. If I get particularly excited and my Murray Mint lands in your lap, could you please return it? But when I went to the Mount Wilga Hospital 3 years ago, we have 140 inpatient beds. We have 90 outpatient beds. And this dear soul who took me around the facility on my day of orientation took me ultimately to the dressings cupboard. Now, this is interesting, the dressings cupboard for all of these beds. This must be quite a cupboard. We stood before this cupboard, and with a glint in her eye, she said, "We can dress anything at Mount Wilga as long as..." It's with Mepilex Border. I thought she was joking, but over the next few days I realised this was quite true. Mepilex Border was on anything and everything, and as long as the wound was covered, the wound was dressed. And the rest of the rehab team went on doing their thing with their goals. A new man of inspiration and delivery. Thank you, Mike. So wound care has been a great source of consternation in the setting where I have been. And let me give you two recent examples. Here is somebody on the left-hand side who's had fractured ankles from the age of 19 years. He is now in his late 80s. And so for the best part of 60 odd years has had no capacity to dorsiflex, has no calf muscle pump function, and has oedema for well over 60 odd years. Has never ever had it explained to him in 60 odd years as to why their legs are swollen. It's just that they've always been that way. He has had 6 operations in those 60 odd years to refuse his ankle bones. Here is the wound dehiscence after his most recent surgical procedure to refuse 1 or 2 of these ankle joints. And just on the day of, in fact it was the day before the case conference, which was to determine his time of discharge, he was told by his visiting surgical specialist to say, "This does not require dressings, this does not require bandages, your swelling is not a problem, you need to have nothing on that wound, you need to have your leg up and in the sun for at least 6 hours each and every day, and this wound will improve." There is the advice on the day before the decision as to when he was going to go home. That's what he was to go home with, that advice. We had another individual with a wound on the top of their head. This was again a squamous cell carcinoma. This was one that had received radiation. Nobody had really decided to have this discussion about whether this was a healable wound or not. Is there something we're actually likely to get better or not? The assumption is all wounds with dressings on must get better at some point, mustn't they? So surely, with a little bit of sloughy deposits on this wound, all that's needed is some good antimicrobial covering. Why don't we send this person home, and they surely can do this themselves, with some gauze and some betadine. And if their wife is there at home, then maybe every 3 hours. Let's put a bit of gauze and betadine on this wound, and then surely this will come good. And we'll find out in 8 weeks' time when you come back for your review. Surely then things will be well. So here is the background from which we start. So why has it been such a problem? Why is rehab so challenged that when we're getting everything else so right about the individual and returning them to the best that they can be each and every day, why is it not working for wounds? The majority of people with wounds are not managed by people who know how to deal with wound care. And in fact, when I look at those who are engaged within our healthcare delivery, within rehabilitation, there is not one group which will have had more than 1 hour worth of wound management training within the undergraduate years. And they are told that what they will learn about wounds, they will learn everything they need to know on the job. And the trouble is, what you learn on the job is what the eminence tells you. This is what we've done, this is how we do it, and I've always done it this way. So that puts us against the brick wall to start with. Wound care when there are comorbidities, and in the rehab environment, if you don't have a comorbidity, then why are you with us? So wound care is complex. I often remember that it's been said that it takes a village to raise a child. It basically takes a village of health professionals to help somebody with a complex wound get better. Again, it is all of us, not 1 or 2 of us, to try and bring this thing to a state where it is a livable entity and somebody's quality of life can be the best it can be. We tend to treat wounds and people with wounds very symptomatically. We're so good at looking at a wound and saying, oh God, what do I put on that? But when's the last time anybody asked, what is that? And here was our problem. Because we were so good at putting Mepilex border on, God, we're good at putting Mepilex border on. You wouldn't believe where we can place that. But did we ever ask what it was that we were putting it on? And one of the other things which I identified as our huge problem is that we didn't know how to assess somebody with a wound, and we didn't really know how to describe the wound itself either. So we weren't identifying the underlying causes to wounds. Why does such a thing exist? How long has it been there for? And linked with this is we weren't quantifying anything. If we don't know how big it is, how moist it is, what the colours are in the wound, and we're not measuring things each time we provide care, how do we know whether we're making a difference or not? And it's stunning to find that you're doing the same thing every second day, and you've been doing it every second day for 6 weeks, and somebody's now making a plan to go home with a wound that was there 6 weeks earlier, but it's no better. Why is that in rehab acceptable when nothing else within our rehab sphere, that would not have been considered an acceptable discharge plan at all? So we've got to be considering, we should be measuring, we should be describing, we should be trying to find underlying reasons for things to exist. We need to perhaps look at wound categorization. You see, we always assume that because when we had a wound, throughout our lifetime, when we get a wound, we always get a wound better, don't we? We assume that we heal and that healing happens with usually a good coverage. But if healing isn't happening, maybe we needed a different dressing. But what happens when we've got a wound and a wound isn't likely to heal? One of the things in our sector we've traditionally been bad at is having that discussion about something which will in fact not get better. And if it's not going to get better, then what's your quality of life looking like today? What are your goals now as we consider that we want you to be the best you can be today, but what if the best you've got to be today and tomorrow and next month and the next 6 months is with a wound that will never get better? What does that begin to look like? But nobody was having those discussions. How do you go and talk to the individual with a wound to say, we actually don't think we can get this better? But we don't think we can get it better because we can't actually tell you why. How can we have this discussion if I don't know why, and therefore I can't tell you why? So there are problems that underlie all of this. One of the other problems that they were obviously having is we needed to go to Mepilex border on everything, because otherwise to open the door to other possibilities is look at all of the products that are out there. The choices are too vast, too great. How do you choose between products? Here was another one of our challenges. So chronic wounds tended to be regularly underreported. And one of the problems is, well, if we didn't know what was causing it, then is this actually a responsibility of something else? Are these people going home because they're actually still malnourished? Are they going home with a wound because it's still infected? Are they going home with a wound because it's actually the vascular surgeon's responsibility because there is not enough arterial blood flow delivery? We found in Oz that one of the big problems we have is that there are great international guidelines, practice guidelines and so forth, but we're not using them. There's great stuff in the literature, but how often does that actually make its way to the workplace? One of our issues is that our clients, when they leave rehabilitation in Australia, because we are a regional referral centre, they leave us and they may then go to far-flung dispersed areas. When you've got somebody who is 2 hours away from their nearest town, when you've got a driveway which from the road to your driveway is itself 20 minutes long, how do you get a community nurse to see you? Therefore, how do we get you to self-care, this idea of what Zena is referring to? We are very much in our rehab environment trying to engage people to be as self-caring as possible, because when you are in far and remote areas, you may be it. So these are our challenges, and a number of these others are listed. I'm now going to fast track through this because I want you to see we've tried very hard to do something about this. I've got 10 minutes left to tell you a bit of a story as to what we're doing now in order to correct some of our challenges. And that's probably Boris listening in right now. So let me just zoom past some of these because I want to introduce you to our wound care leader group. We realised that one of our huge challenges was this void in education, this incapacity to do good quality assessments and make decisions which were meaningful and measurable. Our wound care leader group, we have 19 individuals. They consist of medical officers, nurses, allied health, a podiatrist. All of these folks have been put through our wound care training program so that they, in their clinical domain, can be engaged in the decision-making and influencing of wound care, but also liaising with one another so that our unique perspectives and capacities can be brought together as a collective whole for that complex individual to say that your wound care around your whole rehab goals, that in order to fit into your rehab goals, wound care should look like this. Can you guess in our particular group who our one continence advisor might be? I think she's standing out rather well. But it is lovely to have a real mix of talent. We realise any of this group has the capacity for leadership at any point in time when their particular skill set can lead us towards the attainment of goals which for patients are making a huge difference. Our program in training these individuals is that over 12 weeks, so over 8 weeks, they have 3 hours worth of theory in the classroom, 12 hours of clinical supervision, and that over these 8 weeks they are learning theory, but they are applying theory for patients in their rehabilitation remit. So that as we learn about the anatomy and physiology, as we learn about assessment pathways, as we begin to study the impact of pharmacology, we want this theory to be immediately put into clinical practice and have this reinforced and have this immediately useful. And our wound care leaders have the responsibilities that you see in the box on the right. They have a series of documents which we call the Heidi chart. But basically what we want our wound care leaders to do is when our pool of staff say we have somebody admitted with a sacral pressure wound, with a hip dehiscence, with a massive wound infection, whatever it may be, a person with a wound is identified and one of our 19 wound care leaders is then responsible to do the initial assessment of the individual and their wound and be in a state where everything is now quantifiable. They can flag through identifying comorbidities and so forth, then the strategies that are required that may then require the instigation of the entire group of 19 to say, how do we get this person to have a known etiology as to why their wound exists? Is this therefore then healable, containable or palliative? And how do we design a plan so that we know what we're doing, how we're doing it, why we're doing it, and if it's making a difference or not? These individuals have to write these plans up, and they are the ones to then escalate and de-escalate our activities. They oversee the documentation done by all members of our team. They're also engaged in data collection, and part of this data collection is that we had never, until I arrived with this group, been able to describe the type of wounds that we were seeing. How many arterial ulcers, how many venous ulcers, how many pressure wounds, how many diabetic foot ulcers, how many wound dehiscences. What were coming into our rehab facilities, we had no data on, so we started to collect that data. And we now know over time as to what the core groups of patients are that we see. As we describe the wounds as to which wounds need debridement, which wounds need pain relief, which wounds need odour control, which wounds need various degrees of moisture intervention. We've actually been able to determine the 7 most regularly used products as now our core group in our formulary, based on the data of who it is that we're looking after. I'm pleased to tell you that Meplex Border now has 6 companions in its cupboard. And we can actually now use the right product at the right time for the right wound, based on the strategies that our wound care leaders can now instigate. Our wound care leaders, because we now have documentation, we have an assessment strategy, these are the guys who now each and every week our managers come to them and say, please have a look over all of the patients who are on our ward this week. And as our wound care leaders have their weekly meeting with the managers, they can say, on your wards this week you have these type of wounds, your wounds are presenting with these characteristics, the products you require for these this week are these products. Our managers are now getting in products which are fit for purpose for their group at the right time. They're never locked in for saying this week's now got to match next week. If we are making improvement in our patient's presentation, our stock pool this week may look different to next week. But we respond to what we see as required over the course of that patient's journey and their wound therapy. We've actually found that in doing it this way, we are saving money each calendar month. And in fact, our first month of this system, we saved over £1,500 just by having this system in place. The other beauty of this is the education that these people have received. They now have to pass on to the patient for their work of patienthood, to their family members, to other groups who may be coming in, like our visiting specialists, to say to everybody, this is what we're doing, why we're doing it. And as we start to plan for discharge, these are the pieces of information that these people must have access to, particularly should we require them to have any aspect of self-care and self-monitoring into the future. So, now that you know about that, what I want you to just to quickly see is a couple of patient responses. This is actually from our end users, some of the things they've said about our wound care leader model. The survey, we do a monthly survey. How have our patients seen their wound care under this system? And what they're saying is that individuals with wounds, so it's their clients and their family members or their carers, they now feel that they have a voice and that people are listening and that people are engaging them, and that they can now establish goals which are meaningful because they know what is happening to them and why. They also see the wound care leader as their pathfinder, somebody to guide and somebody to direct them. And one of the things that we have is that when people leave our institution and go all over rural and remote Australia, they have a hotline back to our facility. And if need be, they or their associated health carers, wherever they may be, can call back to a wound care leader and have a pathfinder to say that when you were with us, we did this, this and this because of. Now that you're where you are, your goals might be somewhat different, but as we understand where you've come from and where you're now at, perhaps your activities should be this, this and this, and we will work in with either you, your family member, or your health practitioner to make sure that your care remains in a transitional state, but it is seamless and with few gaps for which you can fall into. Just 2 quick things to show you. One of the great innovations that is happening in Oz now is that in rural and remote Australia, we have experts like this particular group in their truck. We don't have a leg club where people come into the leg club, so we have a leg club truck that goes out to them. And it now means as we communicate with people like Margot Asmus and others, we can now say the care you've begun in rehab can be continuous with a provider who will come to see you at their place, or she turns up into the centre of your town and wound care is done there. We have some very innovative pharmacy providers in rural and remote Australia. And pharmacy providers can actually send you product to where you live. I mentioned some individual who has a driveway 20 minutes long. He can't get down his driveway with his wound, so they fly product into him via a drone. The only one problem we've had with that is that one particular farmer whose property they now avoid thought that there was some commie spying bastard flying a drone over his property, and so he was shooting it down. So we've got around that particular problem. So this is the slide to finish on. Individuals living with a chronic wound, they're dealing with already a ruined body. They are enduring life, wondering if things will ever get better. Sometimes we can be part of the problem if they are enduring us, if we have no plan to help them move forward. We don't have this consistency. We are not part of their goal setting. Now, without wound care leader model, we are not the panacea. We are doing so many things wrong. There is so much for us to learn and do better, but we've made a bit of a start. And when I spoke to Ellie about this is what we're doing, it's actually her fault that she suggested I might just share it with you, just in case some of this might be of value. But thank you to the Leg Club, because really this inclusiveness is something we've now tried to emulate in rehab. Thank you for your time and thank you for listening.